it's on. Hi everyone, we're just going to get started on the next session. So we have got Jane Gao here from Sir Charles Gardner Hospital. She is an ENT Registrar and she's going to provide a presentation on ENT upskilling. Thank you, welcome Jane.
Thanks everyone, thanks for joining me for the last session of these 2 days. So I guess a bit about myself. I'm one of the registrars at Sir Charles Gardner Hospital. I've worked across all the tertiary centres in WA, Fiona Stanley, Charlie's, Royal Perth and the kids. And I've done a few outreach trips to Broome and Kununurra, as would have most of the ENT specialists and registrars in WA. This session is a little bit didactic because it's quite hard to actually bring equipment and share things to actually physically upskill, but happy to take any questions or any sort of things you want me to address. So I know we've got a varied audience, so I'm hoping if there's anything interesting or anything that's a little bit out of scope for today, just let me know. So I guess first about actually upskilling, cleaning ears, which is a big problem across the community. Either it's very limited in terms of where you're working and your practice. Most GP practices will sort of be limited by the equipment they have available to them to actually clean and visualize ears. It becomes tricky when you're trying to diagnose and manage ear conditions. In the ENT sort of specialist setting, we have luckily something like a microscope, which often is very expensive and very difficult to access in the community. But the way we prefer to clean ears is sort of a dry technique, so using microsuction or ear picks or that sort of thing to actually remove debris and foreign body. Ear infections like to live where it's warm and damp, a bit like thrush. So the aim of keeping a dry and sort of acidic environment makes it less favourable for fungus and bacteria to grow. So if you suspect the patient has an ear infection, it's preferable not to irrigate or to essentially toilet their ears by syringing. So what we prefer is all these little torture devices. So on the top left, this one. So this is just a ear hook. I think it's got a fancy name, St. Bart's ear hook. Don't know who St. Bart is. But essentially it's just a bit of a pick. So if you have like a big solid ball of wax, you can just remove it that way. These are alligator forceps, so they're nice and small and they're sort of angled so that it doesn't obstruct your vision when you're looking with a speculum. No one ever teaches you this, so a lot of what I learned is by mistake and by YouTube and that sort of thing. So these are Jobson Horn probes, so they've got like a little wax curette on one end. You can get all of these as disposable or reusable sort of metal instruments. So they've got a little wax curette hook on one end, and it's nice and curved and not pointy, and it's not going to hurt the patient. It's probably one of the best things to use. And then on the other end, it's got this like little spirally thing which you can attach little cotton wool fibres to and sort of tickle any debris out of the ear. These are microsuction tips, so often they're angled as well, so you can actually see what you're doing. In moments of desperation, I have used cannulas, I've used drawing up needles and just bent it one way. It's actually quite useful. You can use them to suction out any debris. They often have a little handle where you can control the amount of suction that goes through. We can get metal instruments like this, so they've got a little hole on the end so you can actually control, sort of open and close the suction. They're very useful for removing any debris or pus, whether it's wet or dry, and then also instilling any creams or ointments. If the patient has, for example, a ear infection that's not responsive to topical drops, you can use something antibacterial or antifungal that's more viscous, like an ointment, and actually just inject it so it covers the ear. And then this is probably what's more frequently seen in the community, a little syringe, and they often have, you can get these little ear tip attachments that kind of splits the water stream into 3 and create a bit of a vortex. So it's a bit more gentle and a bit more aimed at actually flushing out stuff than just simply sort of creating a lot of pressure and irritating the ears. You can get all these fancy attachments to your phone, I guess, or you can get attachments onto an otoscope, which allows sort of clearer vision and more sort of you can sort of see down a tiny little a narrow scope of vision. But the benefit of having something like that or a microscope is that you can actually use two hands, which is the most important thing. So even if you have a headlight, if you've got a headlight with a speculum, allowing you to use both hands is probably the most helpful thing in actually cleaning ears safely. I guess what we see in the ears most commonly and most sort of troublesome are foreign bodies, especially in children. These are sort of the most common offenders. Popcorn kernels, I don't know why people love putting that one in ears. It's so irritating because they're round, there's nothing to grab onto, there's nothing to like stab or poke it, and it's sort of the perfect size and shape to get stuck in the ear canal. Second one, Diamante stickers. These ones are horrible also because they're mirrored on one end and they're flat. So people often, when they're seeing in the ear, they don't know what colour it is, if it's clear or if it's like a big sort of tumour in the ear because it's reflecting half of the eardrum. They're also flat and sticky. Kids love putting these in ears. This is a new thing I've been starting to come across, these beans. A lot of primary schools and daycares love using them for sort of play and immersive kind of sensory therapy. Kids love putting them in ears, and unfortunately sometimes they start to grow and sprout if they've been left alone for a little while. In older populations, the silicone putty earplugs, sometimes love them, sometimes hate them, because when it comes out it's sort of soft and piecemeal. Hearing aid tips, a lot of people, especially people who are older or cognitively impaired, they have a couple stuck in their ears and they don't realise for a long time, and it can start getting infected or just falls out of their hearing aid as they're sort of putting another one in. Earring backs, I didn't put that on the list, but that's another common one that we see. To remove them, the most important thing is having a good light source. So sometimes if you're very adept, having an otoscope is fine, but I think a headlight is best because then you've got sort of something attached to your line of vision and also you've got both hands. First attempt is the best attempt. Try not to do it more than once, especially in kids. They'll never trust you after an unsuccessful first attempt. If you see a live insect, which does happen, drown it in oil. Any oil really is fine, olive oil, Vaseline, whatever you have on hand, because that takes away sort of the irritation of this, sensation of something crawling around in there, and then often it can sort of lubricate the object or just let it float out by itself. Hopefully you won't see these very often. Using an alligator forceps is often quite tricky because most of these things that get stuck in your ears are very smooth and very round. So actually trying to poke it with forceps just sort of forces it deeper in. You'll see a lot of parents who'll come in after they've tried some tweezers at home, and it just sort of forces the object further in the ear canal. So the best thing is to use something kind of angled and flat so you can get behind the object, and then as the child pulls away or as you pull it towards you, it's just kind of scooped out. Only use forceps if it's not round, so something like this, and you can see exactly what you're doing so you're not injuring the patient. This is a slide on tissue spears. I think you've probably heard a lot about otitis media. But essentially this is a technique if you've got something dry and if you've got something wet and you need to mop up, and you can teach these to parents. It's pretty simple. It's less abrasive than using a cotton tip, and then you essentially don't have to actually look or do anything in the ears and just let any wet debris sort of soak up, and it's quite safe to use. You can teach these to parents or teachers or nurses, whoever it may be. Yeah, of course. These are American guidelines, but to be honest, like any tissue is fine. You're not sort of, I guess if you've only got toilet tissue available, ideally not, but if you can. In ears. Yeah. Mm. Yeah, right. Yeah. Yeah. Yeah, different sort of pathogens we don't normally see in the ears. And you're right, like toilet tissue does disintegrate. So if you have nothing else available, there's other options than toilet paper, than probably preferable. But I think, I agree. Like especially up in people with ear disease with long history of resistant bacteria, the toilet paper is not the best way to go. These are, yeah. 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 Yeah, probably not the best thing. These are this is a slide I took from the American guidelines, but point taken. Thanks, Joe. um, this slide is on fungal infections because these often confuse people and they're quite unusual at first look. So with ear infections, they're not always bacterial, they're not always pseudomonas. You can get different sort of fungal infections, and the debris tends to be more sticky and more dry, or less sort of purulent, less wet. Even with an otoscope, you can see that there's like, go back. You can see fungal spores. It literally looks like mold, looks like hairy, and you can see all these black dots, especially when it's aspergillus, which is probably the most common fungal type of infections that we see. And the patient may not always feel pain or itchiness. Sometimes they say it just feels blocked, or sometimes they say it feels itchy, and often comes after overuse of bacterial drops. Like if patients have been on Cipro for weeks and weeks and weeks, the bacteria kind of it dies away, and then the fungal pathogens that normally live on the skin start to cause problems. So the way to treat these is to clean them, so just refer them to ENT because they're quite difficult to clean if you don't have available equipment. And then sometimes we use antifungal drops or creams and just instill them in the ear. These often confuse people because they can look like cholesteatoma or tumour, or it's not commonly seen, but it's easily treatable, especially sort of this kind of picture. Often we get referrals that saying this is earwax or this is cholesteatoma, but they kind of have a characteristic of fungal appearance, and you can always send a swab, and if it's unsure. These will almost always respond to ear toilets and antifungal treatment, or even just keeping the ear dry after multiple ear toilets. This is the one everyone is scared about missing, cholesteatoma. So cholesteatoma is a slow-growing, essentially ball of squamous material where it shouldn't be, which is in the middle ear. Middle ear has the same epithelium as respiratory tract, so it shouldn't have any sort of squamous debris, and if it builds up, it can start to erode the normal anatomical structures and affect hearing. It can become sources of infection. And people are always scared about missing these, but they're not typically commonly seen. Most of these patients will have a long history of ear problems. It's rare that they present out of the blue without any other symptoms. They obviously have been, but most of them will tell you they've had ear problems since childhood. They're non-malignant. Cholesteatoma will not spread to elsewhere in the body. It's a benign growth, but it will need to be surgically treated because it can cause other things like infections that are intractable to normal sort of measures, and also it can affect hearing permanently. The sort of hallmark of a cholesteatoma is often this attic abnormality. So the attic is up here. When you look with an otoscope, you have to look in this region, so above the eardrum, the most sort of superior aspect. And they'll often have other abnormalities within the rest of the eardrum. So like these retraction pockets, which just doesn't look normal. And same with these, you can see the eardrum sort of retracted onto these middle ear bones, the ossicles. And then these sort of earwax looking things in the attic, I wouldn't remove them sort of if, you know, if that's something that's the only thing you see, because there could be a cholesteatoma underneath, and that's often the case. They don't present with, they often present with sort of insidious symptoms. So infection that's just not responsive, progressive hearing loss, it's rarely just out of the blue. Often the clues, they've had lots of previous surgeries, or even like lots and lots of grommets as a child, or lots and lots of ear infections. Their anatomy is never perfectly normal. If that's the case, just refer them to ENT. We're very happy to see any of these. And the management is surgical. And then just another couple of slides of things that we'd be really upset to miss. Speech delay. So often the milestones that I think of in my head is by 1 year they should be babbling, by 2 years they should have 2-word phrases like eat lollies or goodbye mum, that sort of thing. 3 years of age should have like 3-word phrases that kind of make sense if you string them together. 4 years, so on. So if they make inappropriate or delayed, or they're not responding to sort of speech level noises or sounds that are in the environment, even when there's minimal distractions. For example, if a plane flies by at home, or if there are new pets and that sort of thing, and they're not responding to those kind of noises, you'd be suspicious that they're actually not hearing them. Or if they're having sort of problems at school with attention, with learning, with socialisation. You can refer these patients or these kids to, often there's school hearing programs that we've all know about, and Australian Hearing will do a lot of work in kids as well. There's age-appropriate sort of hearing tests. Not all of them will sort of get pure-toned audiograms, but if in kids as young as 2, you can do play audiometry, you can check their sound fields, and so there's no kid that's sort of too young, I suppose, to consider assessing their hearing. And the earlier the intervention, the greater sort of the chances of success. So a lot of kids will benefit from grommets if they have glue ear, which is a very, very common condition. This is just to illustrate how small grommets are. They're tiny. The diameter is about just over 1 millimetre. So in the ear, they look like this. There could be all sorts of colours like green, blue, white. But this is just to illustrate how tiny it actually is. And so in a kid, it helps to ventilate the ears. It helps getting rid of any mucus so that they're not hearing underwater. In other cases, they can benefit from a hearing aid, whether that's something that sort of conducts via bone like this, or just a over-the-ear kind of hearing aid. And in a classroom, sometimes you can get devices where the teacher can speak into a microphone or something that plays directly to the child, so that it amplifies their speech noise when there's other sort of background level noise in the classroom. The earlier we know about it, teachers can sort of move them around the classroom so they're closer to the teacher. You can sometimes access learning support or NDIS, or early sort of access to speech pathology and OT. And then I've got the final slide. Oh, this is a slide on facial paresis I forgot about. So just a sort of a reminder that when you see patients with facial paresis, think about ears. It's not always a stroke or Bell's palsy, or if you suspect it's a facial nerve or isolated facial nerve paresis, you must rule out any ear pathology before you consider before the patient is diagnosed with Bell's palsy. So this could be anything along the course of the facial nerve. Just reminder, it comes from the brain, has to go through the ear and then out of the face. So anything that affects the inner ear or the internal acoustic meatus all the way through to the middle ear can affect the facial nerve. So herpes zoster is a common one. So Ramsay Hunt, a lot of patients who present with a rash or facial paresis or sometimes even hearing loss. Mastoiditis, so essentially when you have inflammation of the nerve along the mastoid segment or the sort of middle ear segment, patients can present with a facial paresis in the context of an ear infection. Cholesteatoma, temporal bone fracture, so they can get a traumatic facial sort of inflammation, or sometimes the nerve gets compressed between segments of temporal bone. Post-surgery and tumour, so either a cholesteatoma, sometimes a schwannoma, or possibly malignant tumours like squamous cell carcinoma or BCCs that sort of have perineural invasion. So often gets missed. We've had a patient recently who was diagnosed with Bell's palsy in the context of previous Bell's palsy, and he had an MRI which demonstrated perineural invasion from an SCC that was up the facial nerve, so he was incredibly upset about that. So just a reminder to think about ears when you come across a facial paresis. And then this is sort of the final emergency not to miss, is sudden sensorineural hearing loss. So patients, when they describe they're waking up deaf, sometimes they don't recognise that it's deafness or hearing loss, and they say their ears feel blocked or full. Often can be associated with tinnitus. The most important tool to you in this case is a tuning fork, or sometimes if there's no access to one, or if the results don't make sense to you, or it's difficult to test them, an audiogram as urgently as possible is recommended. I find tuning forks really difficult as well. Sometimes I just Google it, there's no shame in that. There's no role for a routine CT, but these patients will need urgent ENT referral because a lot of them don't recover when there's sudden sensorineural hearing loss. If you're in doubt, I would almost always recommend starting prednisolone until the diagnosis is clarified. So you can always start them, tell them about the side effects of it and sort of possible different etiologies it could be, and then if there's a formal audiogram that confirms there's no sensorineural hearing loss, or if it's a conductive hearing loss only, you can always stop the steroids at that point. And then these patients need urgent referral to ENT to complete their assessment, and at the completion of oral steroids, they can possibly have intratympanic steroid injections. Sometimes even some of them, there's good evidence for hyperbaric therapy as early as possible, and hearing rehabilitation. So unfortunately, when you have sensorineural hearing loss, a lot of these will not recover spontaneously. And it becomes even more important when it's the patient's better hearing ear, or sometimes their only hearing ear. Always happy to take referrals for this, or if you suspect it, or if you're not sure, we will always see the patient sort of within 1 or 2 weeks. And that's the case across sort of the whole of WA. I think this is my last slide. Happy to take any questions, comments. Yes. So the evidence for high-dose steroids is up to 6 weeks from the initial onset of hearing loss. In a lot of these cases, I would sort of come to a decision with a patient that, you know, the benefit of these after 2 weeks may be very little, and sometimes the side effects may be worse. And I think I would just let them make an informed decision, because after 6 weeks, the evidence for improvement is very, very little, but there's also not many other evidence-based therapies for sudden sensorineural hearing loss. But up to 6 weeks, I would still recommend it. Yeah. 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 They don't really mean anything. Mainly just different brands and different types. So you can get grommets that are different diameters. So like, and that's like 0.1 or point something of a millimeter. So you can get like 1.1 millimeter ones or 1.5 millimeter ones. The difference is quite small. There's different shapes of grommets. So you can get ones where it's like kind of like a spool on a sewing machine, you know, when there's sort of a flange on both sides. So they're the common ones we typically see. So like you can see there's like a round flange on one side, a round flange on another, and then the middle bit sits in the eardrum. And then you can also get ones that are T-tubes, so like a split pin. So the one that's behind the eardrum kind of opens like this, and they're supposed to last longer. They're supposed to last sort of anywhere between 1 to 5 years. It's a bit more difficult for it to migrate out than one of these grommets. And they're often blue or green. But the actual colours, I don't think really makes a difference. It might give you a clue as to what type of grommet it is or what brand it is, but it's really the shape of the grommet that's important. And sometimes it's hard to actually visualise through through an otoscopy, but very rarely you can see like little legs that come out from behind the eardrum. Yeah. And just so you know, like it's the different colours. Because often we get referrals, and you know it's not necessarily a foreign body. It's just a grommet that looks like to be a different colour. Yeah. Yeah. Mm. I think we tend to still use these quite often, but there are some patients, for whatever reason, whether patient factors or disease factors or environmental factors, that just mean their grommets come out more easily. So they're supposed to last about a year and a half, but often there are patients who the grommets come out within a month or two, or sometimes 6 months, and there's sort of no way to know until you put them in and see what happens. But the T-tubes, they're meant to last about 5 years or so. It takes, there are some patients whose grommets stay in for 10 or more years. It's not uncommon. But the T-tube is, you'd still put them in relatively the same way. The benefit is that it will stay in longer, and then for some patients that's a downside rather than a benefit. I think we do probably see more and more patients whose grommets extrude early, and I wonder if it is like a true trend, or is just something we're better at identifying, or the patients sort of present earlier. Because often, you know, they can't see whether they have grommets or not, but if they feel like their hearing has suddenly regressed, or the parents noticed a child has suddenly regressed, it's always good sort of taking a look in the ear and see whether the grommet's present or blocked or whatever. Not many, probably as many as those who extrude early. So the most common sort of reaction, I'd suppose, to grommets are persistently discharging grommets, and those kids often have another sort of pathology that's not adequately addressed by the grommet themselves. If they get persistent reactions, persistent infections, the grommet kind of becomes a foreign body, or creates a bit of a biofilm that makes it difficult to treat the infection without removing the actual grommet. But the sort of biggest problem for the patient is that they're not hearing in that time, because the grommet's discharging and wet, and then they can't go to school without having wet ears, and sort of kids sensing them and feeling embarrassed and that sort of thing. So I don't think we do receive some of these patients, and it's tricky to treat, but probably among the population who benefit from grommets, it's a very small percentage. I think so, yeah. I think if it's not responsive to sort of empirical treatment, it's always good to take a swab. Sometimes you can get MRSA, sometimes E. coli, as you said, and it's just not benefiting from the usual treatments that we recommend. I think it always helps taking a swab. Yeah. Yes. Oh, yeah. Yeah, that's a good question. So grommets, the way we, especially in kids, it can be really difficult to actually remove any debris. the probably the best thing to instill in those grommets are either siloxane drops, because there's no evidence of any ototoxicity even in animal bottles for just siloxane, ciprofloxacin 0.3% ear drops, and that's what we use after inserting the grommets, because we expect it will be like scabby and there's blood. So just those drops 3 times a day for 3 days is normally what I say, 3 drops 3 times a day for 3 days. Or you can use hydrogen peroxide, which is easily available over the counter, and it just turns into H2O and water and oxygen, and it kind of bubbles away any blood or scabs or anything like that. And that's probably what I would recommend. Any other questions? Yeah. I feel like we are much better at identifying them, even from referrals outside of like our usual pathway. Even patients who have like screening at school or with audiologists, or they would obviously rarely come to the emergency department, but I think we're getting much better at recognising them. Any sort of interventions we do now, it's hard to know whether that, like, you won't see the effects of it until decades in the future, you know. So I think kids, I don't know if they have more cases of eustachian tube dysfunction now, and whether that will actually lead to more cholesteatomas in the future. It's hard to know until that time comes. But I think just as a cohort of health professionals, I think we're much better at recognising cholesteatoma. Yeah. It's really tricky because it's something that's often painless and slowly progressive. So patients don't realize they have hearing loss, or they have been putting up with it for such a long time. So to actually convince them to have treatment for it is really tricky. Like, how will they feel the benefit of it if there's no pain, if there's no sort of sudden hearing loss that they have to adjust to, and it's something they've always gotten used to. So with cholesteatoma, I mean, I think you just have to be honest with the patient and let them know what you expect will happen, which is that if it's untreated, it is expected to grow in a lot of cases, and that could worsen their hearing loss, and the hearing loss is unfortunately often irreversible. I think you can monitor it, but it's quite hard to monitor because a lot of it you can't see. So even with in tertiary centres, a lot of our monitoring are done with imaging, with MRI, so it makes it really tricky when you're in the Kimberley. If there's if the patient opts out of any treatment for cholesteatoma, we will always sort of monitor them, because you know they might change their mind in the future, and we can't just deny them of any sort of management. The aim is, especially in kids, is to sort of monitor retraction pockets, so like these, before they get to sort of this stage and becomes much harder to treat. Even patients with treated cholesteatomas will often monitor them for at least the first couple of years, because there's always, as you know, a chance of recurrence or some disease left behind that it's sort of difficult to clear macroscopically the first time. So patients with cholesteatoma, they warrant review on at least a yearly basis, either with otoscopy or with imaging. But like with these, like, you just don't know what's sort of behind the eardrum, so it's really, really difficult. Yeah, but I can understand, like, how would you sort of be motivated to have a massive surgery on your other ear, and have a risk of hearing loss and dizziness and tinnitus forever, when sort of from the first operation, there's not a tangible benefit. Any other questions? Yeah. Mm. Yes. So for air conduction hearing aids, the biggest barrier to success with them are recurrent infections. So if you have in-ear hearing aids that are occlusive and create moisture and in the ear canal, then often that's sort of the biggest reason why we wouldn't suggest it and might try for like a bone conduction hearing aid or something else instead. We get a lot of forms saying, approval for or whether they're medically cleared for their hearing aid, but the most common reason is either recurrent infections in which they would benefit from a different type of aid, or if they have an anatomical reason for that they wouldn't benefit from an air conduction aid. For example, if they've had surgery and the ear canal is completely closed, or if they have some sort of other abnormality in the ear canal, that would mean a different type of hearing aid is better. So that's sort of what we based off. And I actually, question for you: does it always have to be an ENT to medically clear? I don't think it does. For kids, it is. Yeah. 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 Yeah, and the other common reason is we just at the time of the appointment, we just didn't realise or didn't know that was a barrier for the patient to actually receive any hearing aids. There's probably something else. Yeah, yeah, yeah. The most common reason is discharging ears. A small percent will have, for example, if they're kids, if they might have microtia or something else that's relatively obvious that would preclude them from an air conduction aid, but that's much like a much smaller proportion. Mm. Yeah, Joe, did you have something? Yeah, yeah. Mm. 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 It's tricky, and I think if you asked like 20 different people, we probably get 20 different answers. I think the yeah, yeah, there's no continuity. Mm. I think in terms of my decision making, I look at whether the patient has the ability to continue follow up. Like if they're from, um, a community that's very, very isolated and they don't plan to see us for any follow up, then it makes much more difficult to justify putting in grommets. I think I also look at whether they have any other ear pathologies or any other sort of comorbidities, like if they're a kid who's syndromic, or if they have cranial facial deformities, or if they have an existing perforation that's not getting any better and discharging, then I just don't think a grommet is going to benefit those kids. A lot of the patients with like trisomy 21, and they're having 4, 5, 6 sets of grommets that fall out as they are expected to, and then they get hearing loss again and need another set. I think in those patients, it depends on who you ask, but a lot of them would probably benefit from a hearing aid more than grommets and general anaesthetic over and over again. And then the patients who have sort of pre-existing ear conditions that aren't just glue ear, I would be very hesitant in putting grommets into, or if they have sort of persistently, CSOM was like persistent purulent discharge, then I would be pretty hesitant in putting grommets in those kids. And I think everyone, like, no matter sort of what their social circumstances are, warrant just a clear discussion. This may help you. It's temporary. Sometimes the only way to know is to give it a go, and it may create problems, but if it's something that you want to try and you've never tried it before, or if you don't have access to hearing aids and that sort of thing, then if their parents or if the kids sort of are keen for it, then I don't see any reason not to. But yeah, it's a difficult one. I'm not. Mm. 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 Not usually actually, but like the environment can be so different, I guess, from one part of the Kimberley to another. But yeah, it's not something that I've actually thought about very much, but that makes for an interesting discussion. And the other problem with especially ear health in the Kimberley is that as you said, to do any retrospective data or research on it, the data is so sort of dispersed. It's sort of part of it is within wax, part of it is within community, part of it is with earbuzz, part of it is within Australian hearing. So it makes it really, really tricky to actually look at all that data collectively, which you kind of need to. But at the moment, I'm not aware of any research that's going on in that area. I know, like, previously there was a sort of a 10-year retrospective looking at outreach ENT services in the Kimberley, but that was quite a while ago, and it's probably time we do another one, I think. But yeah, I feel like the biggest barrier to actually look at all the research and derive any conclusions is it's actually so sort of spread out. Mm. This is a bigger problem. Mm. 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 I know in like telephone kids, they're doing other research sort of before it gets to the intervention stage, looking at preventions and different like biofilms and pathogens in the middle ear before we actually look at kids who have complications in glue ear. But in terms of the intervention, that's an interesting one, I think. Yeah, we should have a chat. highlights the need for to generate local guidelines and research that come from our cohort of patients, because grommets weren't invented from data collected on Aboriginal, Indigenous, rural children. So we can see the success of having local otitis media guidelines, and especially guidelines that are specific to Indigenous kids. So I think, whether grommets are effective intervention in this population, I think it just really relies upon us to collect our own data and research for it. Mm. 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 Yeah. 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 Yeah, that's an interesting thing. Maybe we should collect some sort of feedback and information after each of the different specialists and see what the variance is like and what the experience is. Personally, after the last trip in Broome, I had very little just cohort of patients who were actually kids with ear problems. They were mostly adults with other problems. Yeah. Yeah. Mm. Yeah. Mm. Yeah, it's a good one. I'll have a chat with Jeffrey next week and see what everyone else's experience is. No worries. Anything else? Any other questions? Ears are hard, so please feel free to ask. Cool. Well, thank you very much for having me. I hope that was somewhat useful, and very happy to answer any questions or chats sort of off the microphone.